And we're back. We have Ney Meziat Philo. Ney, this is your first time on. For people that aren't familiar with you or with your research, can you tell us a little bit about yourself?
I'm a physiotherapist. I have 25 years being a physiotherapist in Brazil. I have just spent a year as a visiting professor at McMaster University in Hamilton, Ontario, Canada. And now I'm back to Brazil. Next week, I'm going to be reopening my office. I miss my in-person treatments of patients with chronic low back pain. And I'm also an assistant professor at Augusto Mota University Center in Rio de Janeiro. I supervise masters and PhD students, and all my research about TechSnack is because of my students' work. And also, I have been doing research on cognitive functional therapy for chronic low back pain, and we have conducted some randomized control trials with interesting results. And I'm focused on, in general, on chronic low back pain and chronic neck and low back.
Why specifically those areas? Why do you like or why do you want to study chronic pain?
Because it's very challenge for me as a physio. I have my background as a osteopath. Uh, uh, was my like the idea that I'm able to treat acute and subacute patients, and most of the times natural history of recovery was 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 playing an important role in this circumstance. And whenever I had chronic pain patients, I struggled, and I wanted to know how to treat, how to help these patients. And then this combination of research and clinical practice helped me to choose what I would research, and also to help me to be more how can I say, to reassess my beliefs as a clinician every day.
Yeah, I found out about you through a recent publication that you were one of the co-authors on that came out a month or two ago, or maybe even more recently. But it was from Brazilian Journal of Physical Therapy. I'll read the title, which kind of gives away some of the findings. But I reached out to the main author, and he recommended I communicate with you. But the title of the paper was cervical flexion posture during smartphone use was not a risk factor for neck pain, but low sleep quality and insufficient levels of physical activity were a longitudinal investigation. So the goal today is to talk about all things text neck and persistent neck pain. Let's start with just defining or describing what people typically think of when they hear kind of text neck as a diagnosis or as a thing.
Uh, in general, it started as I saw like more than probably 10 years ago, I saw on the news that healthcare professionals saying that, oh, this is the a cause of herniated discs, not only neck pain but herniated discs. This is because people are using their phones in a flexed neck posture. So that's why I decided that, oh, let's see, let's check, let's start to conduct these studies, but there is nothing in the literature. Um, and also, there was uh, in the US chiropractor that started to speak about this term, text neck, and he created an institute called Text Neck Institute because he saw a person, a teenager, using her cell phone in a bad posture, and she had neck pain, and she realized that, oh, that's why she had neck pain. So after that, we had a study. It was a biomechanical study of a neurosurgeon called Hans Harsch that published a picture of the mechanical stress on the neck while using a smartphone, and like saying that if you are in this position of like 60 degrees of flexion, you're gonna have 25 kilograms on your neck, like because your head is heavy. And so people started to uh, talk about that. And in Brazil, it was like every single day we saw that on social media, on TV. And that's why uh, it started to, how can I say, be something important, because physiotherapists started to say that, oh, this is, you have to correct your posture all the time. And I started to think that, oh, let's do research on this.
And over the past few years, or the amount of time that you've been researching that, trying to see if there's an association between smartphone use or that cervical flexion position that people typically are in when looking down at their phone, and whether or not that's strongly correlated with neck pain or it's a causative factor, what did you all start to find?
So the first study back in 2016, the paper was published in European Spine Journal in 2018, was conducted by a master student. The results, the first cross-sectional study, we just assessed people using their phones, and we took pictures and sent these pictures to physiotherapists to classify whether people had or not text neck, and also asked the participant, whether they think they have or not this bad posture. And the results was that we found no difference. We found no association. It was conducted with young adults, and there's a small 150 people participate in this research, and people said, oh, it's this quality, methodological quality is not enough to say that there's no association. But we have always to remember that we should prove something if there is an association, not the opposite. I was not doing the research to prove that there's no association, right? I was doing exactly the opposite. The first hypothesis was positive, and so we were not able to find with this first study design. Okay. And then we conducted a second study with a larger sample size, more than 500 people. It's still a cross-sectional study, but with people aged from 18 to 65 years old, and also assessing the habit, actually not just the picture, but also measuring the position they are used to use their phones. So we use an inclinometer, and realize that we did not find, again, we did not find an association between the ones that were in that more flexed position and neck pain or frequency of neck pain. This study was published in Spine in 2021. It was conducted by a master student, again, second master student, Igor Correa, and he conducted also this one, the one that was a longitudinal study. And then we realized that even following these people up for 1 year, considering that on baseline, we had just people without neck pain. 1 year later, we did not find any association or like a risk. It was not a risk factor for uh, complaining for a complaint of neck pain or increased frequency of neck pain.
Yeah, and in that longitudinal investigation, the what was found as a quote unquote risk factor was lower sleep quality and insufficient levels of physical activity. Can you touch on
Yes.
what that looked like and what that means?
Yeah, it was not a surprise because considering the biopsychosocial model, considering that lifestyle factors play an important role in this, how can I say, chronification of pain, but also the like the start of pain, and uh, poor sleep quality and insufficient physical activity. And also, if we see that on the table, we are going to see that sedentary was uh, like almost statistically significant. So there is a tendency in the direction of sedentary behavior to increase the likelihood of reporting neck pain 1 year later, um, and also the poor sleep quality. Of course, everything was self-reported with questionnaires, but it's uh, we find we found similar results for back pain, for example, chronic for back pain, low back pain. Sorry.
Yeah, going to low back pain, the continued common belief that people are having persistent back pain because of their posture, whether it's sitting or their day-to-day posture, and this continued belief for low back pain, but also now for neck pain and this quote unquote text neck, that the static positioning of looking down at your phone or the cervical flexion is inherently going to cause or the reason you have persistent neck pain. Can you kind of touch on these just persistent beliefs around this black and white
Mm-hmm.
thinking of posture and pain?
Yeah, definitely. I think we have to separate posture as a predictor, as a risk factor, and posture as part of a maladaptive behavior. Uh, we can assess posture in a chronic pain patient and then prescribe different posture, change your posture to alleviate your pain. It's different than uh, saying that everybody should be caution, should be should be uh, aware of their posture all the time to correct. So you're gonna prevent anything. So we know that exercise in general, if you do it regularly, it could help us to prevent low back pain and also neck pain. And the focus on posture is based on the biomedical belief that the back, that the spine in general is very fragile, and we have to be careful all the time. And also, it causes pain hypervigilance, in my opinion, because people with pain, with persistent pain, if they know that, uh, oh, maybe it's my fault because of my posture, they start to get hypervigilant and they don't relax. And this is not good. This increase the muscle activity. You have link between pain catastrophizing and increased muscle activity on trunk muscles in people with chronic low back pain, for example. But also we know that chronic neck pain affects gait. For example, there is no the dissociation during gait is decreased. There is this increase, and there is evidence that it was a study conducted, published in Physical Therapy a couple of years ago, showing that women with more straight posture, they have an increased risk of developing neck pain. I'm not sure if it was neck pain. I think it was chronic neck pain in the future, and we don't know, but maybe it's related to a behavior of hypervigilant behavior, more anxiety, high levels of anxiety. And that posture, that was like this lump posture, was not associated, and sway back posture is not associated with pain. So we have these similarities between the back, the lower back, and the neck, that showing that posture is not something that we are gonna, if we change, we are gonna prevent back pain in the future.
That being said, there's still likely benefit to having, whether it's low back or with neck, having changes in posture or movement variability throughout the course of the day or for an exercise routine, not with the narrative that someone's prolonged flexion, sitting position, or looking down at their phone is inherently bad, but changing that position has general benefits for a variety of reasons. Can you go into, from an exercise perspective, for either persistent low back pain or for persistent neck pain, how specific do you feel like treatment needs to be from an exercise perspective of really focusing on this position or the strength of the back or of the neck versus general movement and exercise that can be more exploratory in nature and more broad for each individual?
Definitely, I agree that the variation of posture is maybe the best way to prevent back and neck pain in general. But also there's something important that is like awkward postures, posture that you are not used to be in, like to adopt, like it's not bad posture. It's something, an activity that you had to do, but you're not used to that. So your body is not conditioned to that specific activity. It could be a trigger to a pain. We have to consider that. That's why every activity, if you start to do regularly, in a graded exposure way, it's gonna be, most of the time our body will adapt. But in terms of exercise, I have the bias of cognitive functional therapy, and I think that I believe as a clinician that if we focus on the specific activities, like I like to use the specific patient and specific functional scale, and focus the treatment on that activity that is limited, instead of just, I use the ODI, the Oswest Disability Index, and in general there is or neck disability index. In general, there is a level of disability, and let's do exercise in general without focusing the specific limitations. I think this is not the best approach. I think if our approach is patient-centered, we should focus on that activities, but also add exercise as a lifestyle balance or change. Not too little, not too much. Sometimes maybe there are people with high levels of self-efficacy. For example, some kind of athletes, sometimes they need to rest. Just it would be enough. But for most people that attend studies like our clinical trials, most of them had low levels of self-efficacy. So we had to motivate them to be more active, to engage in a physical activity that they chose. So this is important, their preferences, and understand that I like to use the term not resilient, but anti-fragile. Like your body, if we start uh, to train, we are most of the time we're able to adapt as long as it was a gradual exposure. Exposure.
Yeah, so your framework is very person dependent based on their limitations, their preferences, their hesitancies with certain movement, and gradually exposing them to the thing that they're either avoiding or want to get back to or need to get back to for their life or for their physical activities that they enjoy. Can you maybe dive more specifically into what that may actually look like, either like a random mock case study or something more specifically that you've seen in the clinic the past few weeks or months of someone's having persistent neck pain or persistent low back pain, they're minimizing or they're restricting certain activities. What does that process specifically look like for you?
For example, a patient that I treated online while I was in Canada, a patient from Brazil, we had just one session. It was surprising that he had just one session, and then he started to send me evidence-based posts from Instagram, saying, like, reinforcing what we were talking, and I got very surprised because he changed completely his beliefs, and he started to train again, like wait, like started to work out, to go to the gym and work out. And what I said was that if you go and what do you want? I want to be able to go to the gym again and do exercise as a normal person without thinking that, oh, I'm doing that and my disc is gonna be smashed. So because I'm doing wrong exercise, and he started to send me posts that saying that, oh, it's not an issue because you're doing can I say um, any exercise that your back is flexing, it's not an issue. It's a natural movement, and he started to feel more safe at the gym and do the exercise he needed. And another good example was uh, like we conducted a trial with patients with chronic pain after spinal surgery. This patient had a very high levels of catastrophized anxiety, depression. So because they have already tried all the different ways of treatment, and they got very frustrated. And for example, another patient that I treated during the pandemic, he attended a clinical trial we conducted in Brazil, in Rio de Janeiro, but he was following me on Instagram, and at the middle of his sessions in the clinical trial, he said he asked the physiotherapist, the treating physiotherapist, that to talk with me. And he said, oh, I think this treatment was not exactly what I was expecting. He was randomized to the control group. The control group was manual therapy and a motor control exercise focused on transversus abdominis and multifidus and that idea of stabilization, segmental stabilization, and he improved a little. But 1 year later, I told him, please focus on the trial. You're going to receive a call. And if after a year, after the last follow-up, if you're not better, please let me know. And he sent me a message during the pandemic. And we started a treatment completely different than the control group that received the cognitive functional therapy. And his aim was to return to the gym, and he had a small gym in his home, small room. And in this, I think in the second session, I started to ask him, let's go there, show me your gym. And so, uh, could you do, how can I say this, supine? I don't know, supine. I like chest press. And no, I tried, but I'm afraid of it. So if you use just the bar, can you do that? How many repetitions? Oh, can you do 6 or 4 and 6 repetitions? Oh, yes, no problem. And he started by doing like a low number of repetitions, then increase the number of repetitions, and then include like 1 kilogram each side. And we had that all this recorded. And very interesting that a person with 2 surgeries got he got absent from his work for years, so because of his chronic condition. And suddenly he went to the doctor to decide whether he should or not go back to work. The doctor saw him and thought, oh, you are too strong to stay home, so go back to work. And he got very nervous. I remember that, oh, do you think I'm able? And I said, yes, but maybe that chair from work, that it's not good for me. Maybe, oh, let's do it. Okay. And after I realized that, no, I'm sitting more relaxed, and then I'm able to deal with this, like spending 6 hours or 7 hours or 8 hours sitting again. And so I focus on every activity the person consider important and limited, but also I try to evoke, we call the bright spot, an physical activity that the person enjoy doing. So this is going to be good for the nervous system, for the body in general, if we are able to do that. And also we have to consider sleep quality, sleep hygiene, and like the making sense of all these aspects is important. Like to understand that pain is the biopsychosocial nature of pain, and each aspects are influencing that pain. So this is the way I treat patients. And the research we have been conducting is reinforcing that the results, or the result of our last randomized control trial, placebo control trial for CFT for chronic low back pain, showed clinically important difference. And I think that we we I expect the same results for chronic neck pain. But of course, we should conduct clinical trials, and we are planning to conduct a clinical randomized control trial to check whether the same results for low back pain are applicable. We can apply the same method for neck pain. But in general, there is no like biological plausibility to think that is going to be different, because it's chronic pain and it's related to the spine. There is the idea that we have to protect our back. And so there are results from MRI scan that are about the same. Like there is evidence that genetics play role in the development of degenerative discs, both in the lower back and the neck. So I think this is going to be um, important, but as a clinician, my belief is that neck pain and low back pain, I think the results are the same if we consider the biopsychosocial model, patient-centered approach, not only CFT, but also there are other approaches considering the biopsychosocial model that I think are going to be very successful to help people with chronic pain.
CFT sounds like listening to the person, maybe describing or trying to provide a more updated view on um, helping them understand kind of the chronicity of their symptoms, understanding that there's so many variables and layers as to why someone may experience pain, and then understanding their concerns, their limitations, and slowly working them back into the things that they want to do in a graded exposure format. Is there anything I'm missing with cognitive functional therapy? Like, is there more specific types of treatment, or is that the general gist?
Yeah, that's the general approach, but I think there's the link between the making sense and exposure with control is very, how can I say, is something that is different from other approaches. Is not a combination between just, for example, pain education and exercise and graded exposure. It's not the same because there is this link. The interview is focused on patient's story much more than speaking and explaining about pain. Most of the times we don't use pain education, like sometimes you can use metaphor, sometimes you use the evidence, but not at the beginning of the session, because we should be concerned about the therapeutic alliance. If the therapeutic alliance is enhanced and the patient has an experience, a behavioral experience, like that's, imagine if there I am not able to bend over, I'm very afraid of bending over, and then after relaxing, after talking a little bit about that and realize that I was too uh, tense, and then I relax, and now I am able to do the movement. And there is we call expectancy violation. And this, after this expectancy violation, if we talk a little bit more and explain a little, it will be well accepted, much more than before. You know what I mean? Like sometimes we start to run a class, like to run a lesson to patients, and it's not working. It's like they have sometimes something called backfire effect. That is, and they, what is he? He's telling me something that's a completely against, is the opposite of of my beliefs. And instead of being flexible and accept and try to change, no, it's reinforced my beliefs. And sometimes the biomedical model gets stronger because we are not using the proper way to help people understand and make sense. So that's why therapeutic alliance, like we use many techniques from psychology, like try to understand facial expression, body language of patient all the time, and during the graded the controlled exposure. And the controlled exposure is, or exposure with control, is fundamental that we check whether patients are contracting or not. For example, trunk muscles in chronic low back pain patients. They are not breathing, they are tensing up, they are expecting that they are not feeling safe. So safety, I think it's called safety learning, is something that I would like to achieve, like to help them feel safe during this exposure. If they don't have the belief that, oh, I'm doing something that cause damage, I'm doing something that might cause pain, but pain is not a synonym of damage. If they understand that, they can do much more. They can risk themselves much more.
There's plenty of individuals with chronic neck pain or low back pain where they're not fearful of movement. They don't have negative beliefs about activity and further damage, and maybe they're not super guarded, but they just have persistent symptoms, but they're doing all the things that they value and want to do. Specifically, I had a consult with an individual yesterday in the clinic who's had a year plus of persistent neck pain, localized to the left side of his neck, exercises multiple days a week, cardiovascular exercise multiple days a week, goes out and hikes with his family, has tried tons of different treatment over the past year, and is just really frustrated because he still has symptoms. He's not displaying any fear avoidant behavior. He's not extremely guarded. He has full cervical range of motion. Those are the contexts or the situations where it seems more challenging to me because I don't know where to go from there. They're exposing themselves to all their valued physical activities. They're staying healthy and fit. They're just frustrated because they have long-term neck pain. How do you manage some of those contexts?
Yeah, great question. Because these are not the case we see in most clinical trials, but it's very often challenging because guidelines say that you should provide exercise, more and more exercise, right? All the time. But I don't agree. I think there's but I would change that because sometimes, as I told you, sometimes these patients, they have high levels of self-efficacy, and they are constantly evoking their pain and that, you know, a little bit of protective behavior, but not as much because they have high self-efficacy. But sometimes they are sad. They are doing all these things, but they are still, oh, I'm still in pain. I'm not happy because I can't do the things I love without like enjoying it, right? So my hypothesis, my just hypothesis for this case is that there is high levels of self-efficacy. I don't know if you have heard about a model that is different from the fear avoidance model. It's a model that is considers the resistance. The people that are fear, they avoid, they have a fear avoid behavior, but there are people that resist. They had at least, I always say that you have at least athletes. So, you know, if they are not athletes, they have this behavior of athletes, and they struggle to rest. To I today, for example, 2 days in my during my week, I'm gonna rest. Rest. It means that no physical exercise, and they are always, oh, I must do something. They get anxious for that. Sometimes after talking with them about that, because you have already tried everything, and now let's do something to balance your activities. For example, I realized that people that were used to play tennis, when they included beach tennis. It was a fever in Brazil. I don't know how is that here, but here in Brazil, it is still a fever, beach tennis. And people were playing tennis in the morning and beach tennis at the end of the day at night. For example, they were uh, feeling shoulder pain, elbow pain, and sometimes even back pain. And then it's not easy to convince them that, oh, don't do both in the same day. So let's rest one day without exercise, because they go to the gym, they go to the beach tennis, the tennis, and running. And so I think that most of the times there is something related to high levels of self-efficacy without they they're not aware of it. They do that, and they are very addicted to exercise. Okay, exercise is good, definitely, but maybe your body needs to rest a little bit more, and sleep. For another example, are people that triathletes. Is it correct? Triathletes. They they are not professionals, but they wake up at 4:30 in the morning to practice running, swimming, and cycling. So it's too much, because after that they have to go to work, and so they arrive home at night and they sleep at, for example, 11, or so they sleep much less than 7 hours. And then they start to develop pain, persistent pains, and it's very common. So that's my hypothesis for that this behavior, that you don't see anything, that is like that they're not afraid. They have like a too good lifestyle in some aspects, but sometimes sleep is not good. But it's something that if we check, maybe it could help.
Yeah, you're describing this kind of endurance coper that's trying to do all the things
Exactly.
and kind of push their way through symptoms in the way of that's their way of coping, that's their way of enjoying things. They don't want to or feel like a sense of loss if they are doing less, but sometimes doing less is the best thing. And for others, it's the under end of the extreme where they've pulled back and reduced so much from their life that they're doing very little and everything is symptomatic, and trying to expose them to the extent that they can tolerate and build them over time. And those kind of different humans, it's different thoughts of how to manage. The ultimate question I guess I have for CFT or chronic neck pain or low back pain is, you can provide the best treatment options. You can try to help someone towards their physical activities that they want to get back to, or modify the things that are really aggravating. But is your narrative with patients that if we do these things and we get to a better place, we're going to eliminate your chronic back pain or neck pain? Or is the context or the story around this management that we're going to help you live life to the best that you can despite having persistent symptoms? Where's your head at with chronic pain and whether or not it can actually go away, and how you describe that or converse with patients about that?
Yeah, this is a very, very important question. And I I always think that talking about hope, we should not say, so, oh, there's no cure. Like, this is too bad, right? On the other hand, we should not say the opposite, like, oh, you're going to be completely free of pain. So it's not true. We know that uh, that's why we have a booster session. Booster session is a session after 6 months, for example. Cognitive functional therapy is important. Um, But I think that we should talk about that with patients. I talked last week or 2 weeks ago with a Canadian patient I am treating, and she told me, we talked about that because my aim is to help her decrease or completely her functional or her disabilities, and increase completely his function, functionality. Yeah, I mean, based on the patient's functional scale, yeah, patient specific functional scales. And sometimes we choose 3 activities, and then, oh, all of them are okay. The person is not 100% free of pain. So sometimes the pain is like this, and flare ups, and almost without pain, completely for a while. And she told me that she started to forget back after 6 years of chronic pain. And that's great news. So it doesn't mean that you're going to be this way all the time, because there is life. There are all the factors interacting, and we don't have control. So I I believe that we should talk about that with patients, telling them that the improvement most of the time is like this, and sometimes you have a flare. But I prefer to focus on uh, increasing function and self-managing pain. For some patients, we are gonna see that, oh, I haven't had pain for 3 years after your treatment. I haven't had any flare up. So it's rare. It's not common, but it's possible. That's why if we say that, oh, there's no cure, you're gonna be so, it's not good for those that are able to have that, to self-manage without any pain. Or maybe after 5 years I had a flare up, I have another new episode of acute low back pain, because I had a huge stressful life event, and after that my behavior, my psychosocial aspects were very too strong, that the person had an acute pain. So because it's, of course, it is, there are all these memories about that painful area that we can't delete from our brain. So we know that. Uh, but I'm very positive about that, because I focus on function, and for some, I think function, most of the times we are able to uh, increase it to 10, for example. Uh, but pain is very difficult to say that we do not have pain. So I would like to have a treatment that I'm able to provide, to say that to my patients. But of course, you're going to see people promising that everywhere, right? And sometimes it's difficult to compete with these pseudoscience-based interventions, right? In the US and Brazil, everywhere.
Yeah, the way that I've kind of gone about realistically or optimistically describing it is, I feel confident that we can move you in a better direction to the things that you want to do, or get back to more of the things you want to do. But I can't confidently tell you that you're not going to have any level of symptoms for the rest of your life. Pain is messy, and it can be a moving target, and it has these undulations. There are a lot of things we can do to help dampen down or minimize some of those intensity of your symptoms, but trying to completely resolve them for the rest of your life is something that I can't guarantee. That being
Yeah, I agree.
said, there are individuals that can experience substantial long-term symptom relief even if they have persistent pain, but the norm is that there are these undulations and there are these flare-ups for a variety of life reasons, and when and if those do occur, we have options, or we've gone through this conversation around how to manage when these spikes in symptoms occur. And I think that's one, relieving for the patient to hear, and two, for the therapist to not feel so strongly attached to, I have to get this person, quote unquote, fully better, because that's not realistic and that's not what most of the research around persistent pain suggests.
I agree. Yeah, yeah, I agree that we should be reasonable in this. The words are very important, so we should talk about that with patients and with realistic aims, and discuss that we must be patient-centered, right? All the time. And maybe there are people that they say, oh, I would like to get rid completely of my pain. And the others are focused on a little bit more on function. And we have to respect that. And sometimes we have patients that they don't want to be physically active, right? We have to respect that. Sometimes I want to enjoy my sedentary behavior. So we have to respect also that. So instead of trying to sometimes difficult for us, because we hear that, oh, exercise is the best medicine, so for everything. So, but sometimes if I heard from a patient that told me that now I'm happy, I'm doing just probably insufficient levels of physical activity, like doing some exercise, but I'm happy because I don't have that disability, because my beliefs have changed a lot, and now I'm doing the things I used to do, but in a way much more relaxed and doing much. I can walk more, go everywhere, and then maybe it's not. It's considered insufficient, but it's much more than that behavior, protected behavior.
Is there anything with text neck or persistent neck or back pain that you want to touch on or summarize before we close things out, Ney?
Yes, after all these studies we conducted, we decided that it's enough. After a longitudinal study, 2 cross-sectional studies, 1 longitudinal study, and also there are other 2 studies from a group from Italy and another group from Brazil. They found the same results. All these studies that assess that disposition, that people say that's a bad posture, uh, is the way physiotherapists used to label, because physiotherapists used to label that, oh, that posture is bad, right? So people ask me, but you just assess once, just on baseline. Yeah, but this belief is the belief that we see people in this position. So, oh, that posture is bad. So I think that text neck is the habit of being in this position. And also we conducted scoping review. We published in European Spine Journal, I guess 2023. It was a study of one of my PhD students. We did scoping to define text neck, and considering a huge number of studies, text neck is the posture, the flexed posture adopt as a habit, but uh, we don't need to. Oh, let's see, how much time this person stays in this posture. So of course it would be not good to know, but in general, since we don't have evidence that posture is a risk factor for spinal pain, I think the likelihood of finding or of having new studies showing different results is very low. That's why I decided that it's enough for us, because we have tried a lot. It's cost it's too hard to conduct these studies. It's not easy. In Brazil, we don't have, the funding is very limited when we have. So let's move to a different research topic. And that's why, that's the message, the main message. Let's stop propagating, I don't know, let's stop spreading that text neck is a public health issue. It's definitely not. Our backs, our spine are resilient, are anti-fragile, and we should reinforce that to patients, to feel that if they try to recover their functionality doing exercise, if they have a better lifestyle, it would be much better than trying to focus on posture. And I would like to say that all treatments that focus on posture must try to adapt to the science that we have today, nowadays. So we have a very interesting study that is about to be published, that we, just to end with that information, that we compared Pilates with all the contraction of the contraction, the core, the abdominal, the transversals, and Pilates, the same exact exercise with the suggestion to relax. And I will not tell the results, but it's gonna be very interesting.
Well, I appreciate all the work that you and your colleagues are doing, and I agree. Maybe it's not necessary to continue studying these relationships between posture and pain and move forward. Anything else? Any other ways people, if they want to hear more from you or learn more, how can people find you?
I am on Twitter. I am X, actually. I am Ney Meziat. And on Instagram, I'm gonna start. I should start to not only posting on Portuguese. I always posting uh, for not only researchers but physiotherapists, but also patients. I'm gonna start to do that both in English and Portuguese. I have a YouTube channel, uh, Ney Meziat. I think his name is PhD. I guess, yes. And there is there is an interview about cognitive functional therapy with Professor Andrea Furlan from Toronto University. That is in English. It's interesting, and yeah. And if any information, if somebody wants to send me an email, my email is NEY Meziat, Meziat, at gmail.com.
Perfect. A lot of ways for people to reach out and get more information. Ney, this was great. We'll call it there. Thank you.
Thank you for having me, Chris, and for this opportunity.